Alrighty, so here we are, second half of the chapter for the knee. Just wanted to kind of hit on some things of class overall as things are been kind of progressing through this closure time. If you guys are feeling good about how we're doing things, I'd like you to email me and let me know. And if you have some suggestions for some changes, I'm open to trying some different stuff. I thought this worked well because you guys can view it at your leisure. Because I know you've got a lot going on with other classes, but if you'd like to get together and have a Microsoft Team meeting, we can do that, and I could go through, when we get into the next chapter, we can schedule those things. I just felt like this was the easiest way for you guys to get the information and not kind of have you guys have to sit down in front of the computer at a specific time. So let me know, give me feedback, send me emails, and we'll see how we can move forward here. So we're going to get started with the second half of the chapter, which focuses on the injuries of the knee. And we're going to talk about specifically the MCL right now and grading it 1, 2, and 3. But this will also apply to the other ligaments of the knee too. When you heard a ligament, it's called a sprain, as in the difference of with a muscle, it's a strain. So we're going to talk about sprains, and we're going to talk about grading them. Grade 1, 2, and 3 sprain, but we're going to start with our MCL. So the MCL is on the inside of the knee, or the medial aspect of the knee. It runs from the medial femoral condyle down to the medial tibial condyle across the joint line. The way it's injured is a medially directed valgus force from the lateral side, or even a lateral rotation of the tibia. And if we go back to the varus and valgus test, you can see that that's this kind of force right here. This valgus force, medially directed, injures the MCL. There also could be a twisting of the knee where you get a similar injury. Okay, so we're going to grade these out. So in a grade 1, and this again will be very similar to all of our ligaments, there's a very few ligaments, fibers that are actually torn or stretched. The joint is going to be stable, okay, when you do a valgus test. So this patient's going to complain of this twisting injury or this laterally directed force. Medially directed force. But the joint is going to be stable when you test that ligament. You're going to have little or no joint effusion, some joint stiffness and point tenderness on the joint line, on the medial joint line, and they're usually going to have full passive and active range of motion. So that means they can move it, and then you're going to be able to move it just fine. Grade 2 usually involves moderate tearing or partial separation of the fiber. So this is where we're going to have a little more separation. Okay, there's no gross instability, meaning there's not a lot of instability, but there's going to be a little extra movement when you test this ligament. A little more swelling now, more tightness and stiffness, okay? And then, again, I definitely have some pain along the inside of the knee and just general weakness and instability. Grade 3 is going to be where there's going to be a complete tear. There's a loss of medial stability, so they're going to feel like it's giving way. Minimal to moderate swelling. There's going to be an immediate severe pain followed by a dull ache, because when you tear a ligament, you're tearing the nerve fibers. There's going to be loss of motion due to effusion and hamstring guarding. Okay, whenever you tear a ligament, some muscle group is going to activate itself to help control the joint, and it just so happens with the hamstring that with the MCL that it's the hamstring that is what it's going to go ahead and start contracting to control the joint. And obviously in this case you're going to definitely have a very positive valgus test. And here's what it looks like. Medial directed force from the lateral side, medially directed from the lateral side, and you have, this would be a pretty close to a grade 3 MCL sprain. How are we going to care for it? rest ice compression elevation for at least 24 hours. Basically, when we talk about these, those 24 hours could be longer if it's a more significant injury, less if it's not as significant, just depends. Crutches and a knee immobilizer are necessary in most cases. Obviously, in definitely a grade 2 to 3, you definitely want to be on crutches and a knee immobilizer for a period of time. Probably from the athletic training standpoint, you're going to want to get them to a doctor in a grade 2 or 3 situation. Progress from isometrics, where there's not movement with exercise, to stationary bike, to stair climbing, and then resistance, flexion, extension exercises. Definitely when you use a brace when attempting to return. Conservative non-operative treatment is recommended for isolated grade 2 and grade 3 MCL sprains. So only when they're isolated, meaning all by themselves. And it's honestly going to be rare that you have these situations because the medial meniscus has part of it that's kind of integrated with the medial meniscus. So a lot of times the meniscus along with the ligament will be torn. And it's very also likely that the ACL would be involved in this. And that's what we call the terrible triad, where you have an MCL, a medial meniscus, and an ACL tear. Obviously, in that case, we've got to get surgery, especially if you're going to continue as a competitive athlete. When athlete is allowed to return to full participation when they regain normal strength, power, flexibility, endurance, and coordination. Now, when we say usually takes 1 to 3 weeks for recovery, that's probably more of a grade 1. Grade 2 and 3 is going to be longer even without surgery. Okay, now we talk about a lateral collateral ligament. So if we go back to our varus and valgus test again. Now it's this force, a medially directed force, okay, towards the lateral aspect of the knee, okay. A laterally directed force towards the lateral aspect of the knee, on the medial part of the knee. I keep getting this messed up. So medial is where the force is, it's directed laterally. Lateral is where the force is, and it's directed medially, just to make it clear. Okay, so LCL. It's very uncommon to have these injuries because it kind of has to be the right situation. Usually you have to kind of step forward with your knee to expose the inside of it to have this injury occur. So a lot of times with this injury, you're going to have a little bit more of a bony involvement because there's a lot more stability on that side of the knee, and ligament is more likely to kind of pull that bone off. Signs of the injury: pain and tenderness over the ligament, swelling and effusion around the LCL, joint laxity with the varus test. Pain is greatest with a grade 1 and a grade 2, and in a grade 3 there's an intense pain followed by the dull ache, just like with the MCL. So management of this is going to be very similar to an MCL when you're dealing with it. ACL. So ACL tears are more likely to occur in females and in males due to biomechanical differences. So there's a whole lot of research out there that talks about why women are more likely to get ACL tears than men. It's related to, they talk about a lot of times related to hormones. It's also related to biomechanics of females, wider hips in relation to their knees, the notch where the ACL sits, and let's go back to a picture. So this notch in here, so the ACL is here, and this notch, they found that in most females it's smaller. So there's less space. You get that rotation for the injury to occur, and there's less space in there, so that's why you end up with more likely a tear for a female than a male. Most likely, usually going to be due to a deceleration, rotation, and valgus stress to the knee. The most common non-contact mechanism of the ACL is when the athlete decelerates with the foot planted on the ground. ACL is being injured in contact injury. ACL is at risk of being injured in a contact injury because the athlete is decelerating and usually changing directions. Okay, so remember, we talked about the ACL controlling anterior movement of the tibia on the of the femur on the tibia. So in that case, when there's that deceleration happening, if the ACL fails because of the motion that's happening there, it will tear. Okay, ACL signs of injury: an audible pop followed by a severe pain and disability. Rapid swelling at the joint, initial pain followed by some relief, and a positive Blockmans. So care for these: immediately rest ice compression elevation. Obviously, most of the time with these, we hear about reconstruction of the joint. I've come across injuries at times where you have like a grade 1, 2-ish, where you can conservatively deal with these, maybe doing some rehab, getting them through the season, and maybe doing surgery afterwards, or maybe they don't need surgery at all and they're just braced. But I would say in 90% of the cases, you're going to go ahead and have to do a reconstruction on these ligaments, and it's going to be about 4 to 6 months of rehabilitation until they can return. There's a great debate on braces. It just all depends on your doctor. Some doctors like them, some doctors don't. If they're confident in their surgery and their skills in the OR, they're probably more likely to say, you know what, I'm going to let it go. But for the most part, braces are not going to necessarily keep you from tearing a ligament. It's more of a psychological help. Okay, PCL, or posterior cruciate. So the ACL sits in front, anterior. PCL sits behind that, posterior. Less likely to tear these ligaments, like they're very similar to the LCL. So the way you're usually going to injure these is falling with your full weight on a bent knee with the ankle and foot in plantar flexion. So if I was able to show this to you, it would be a lot easier. But think about if you're coming down and kneeling, okay? As you kneel, your foot plantar flexes out of the way and exposes the front of your knee, and that tibial tuberosity, or that bump that you feel just below your kneecap, or not just below, but a little bit below your kneecap, that bony protuberance hits the ground, and that will allow to push your tibia back, and that will tear your, or at least injure your PCL. So think about that as you kneel down, and it exposes that. If you came down with a hard force on that, okay, that's where we're going to see these injuries. Very commonly called the dashboard injury, because if you're sitting in a car and your knee is exposed to the dashboard and it gets pushed back towards you, and if it hits that tibial tuberosity and pushes back on the tibia, that can lead to that injury also. So signs of this injury are a pop, like you would hear with really any ligament that tears, tenderness and swelling, and what's called the popliteal fossa. So basically, if you feel behind your knee, there's that space back in behind the two tendons of your hamstring that you feel very prominent. That's your popliteal fossa. So you're going to have tenderness and swelling back there because that's where your PCL is. And then you're obviously going to have laxity with the posterior drawer test. Again, in that test, just to remind you, you have the athlete sitting with their foot under your leg, and you grab their knee in the front and push backwards. So if that PCL right here is torn, it's going to move back. Care again is very similar to the other ligaments: rest ice compression elevation. Non-operative in grade 1 and 2. Controversy over grade 3, what to do. Very similar to your LCL, MCL. You don't have to fix these like you'd have to fix a grade 3 ACL, but you definitely probably are going to very strongly consider it if you have a tear, a grade 3 tear of your PCL. Okay, more injuries. Meniscal injuries. These result from weight bearing combined with a rotational force. So think about our meniscus, our soft tissue. You've got bone on either side of the joint. If you bring pressure down to that and twist on it, it's going to cause a tear. The medial meniscus is more prone to disruption through rotation and valgus stress. Okay, so when we get a valgus stress, we usually get an MCL injury. So we have MCLs and meniscus coming together a lot when they're injured. Signs of injury, absolute diagnosis is very different, or it's very difficult. It's very hard to do special tests to figure out if this injury has occurred. So a lot of times it's going to be a lot of kind of guesstimating, usually leading to MRIs before we really see for sure what's going on. May also really end up with having to do a diagnostic arthroscopy where you actually go in the joint to see if it's actually torn. Effusion developing over the first 48 to 72 hours. That's why I usually tell injured athletes that sometimes we really don't know what's happening with the knee injury until we give it a couple days to see what happens with it. We have joint line pain of loss of motion, intermittent locking, okay, because we have the soft tissue in the joint. It may tear, it may flip up and cause the joint to not be able to move properly. Anytime you get swelling in the joint, it's going to cause giving way or instability. And then anytime you squat, you're putting a lot of pressure in the joint, and that is going to cause pain with squatting. Again, we're going to do our ICE. Forgot to change this. This would be RICE, not police. If the knee is not locked, but indications of a tear are present, further diagnostic testing may be required. A knee that is locked. Sorry about that. A knee that is locked by a displaced meniscus may require unlocking with an athlete under anesthesia. Okay, because you're going to have to manipulate the joint a little bit and it's going to hurt. So we want to make sure they're comfortable. If discomfort, disability, and locking the knee continue, that's when we're probably going to need arthroscopic surgery. A torn meniscus can be repaired by using sutures in some cases. Surgical management of meniscal tears should make every effort to minimize loss of any portion of the meniscus. So just to talk about a few things with the meniscus and how we take care of them, let's go back and take a look at what the meniscus looks like again. Okay, so this is our lateral meniscus and this is on our medial meniscus. So we talked about if we have severe enough locking and pain, we need to go in there and take a look and see what's going on and possibly fix it, okay? If they're able to function and we can calm the joint down, get better range of motion, do some therapy, they can return to the field without surgery. So we talk about what meniscus is hurt and what portion of it is. So if we get a lateral meniscus injury, we feel pretty confident we can repair it. So let's say we get a tear right here. We can go ahead and suture that up and it's going to heal pretty well. We go over here, keeping in mind that we just said we want to do everything we can to keep this thing intact and making it look as close to this as possible. Obviously, sewing it and putting it back together would be the best case scenario, but look at this. Our blood flow isn't so great. So if we sew that up, are we going to have a good outcome of that? Maybe, maybe not. So that's for the surgeon to figure out. If we get maybe we get a tear in the back here, we can do that. Or here, there's some blood supply, but this is very limited blood supply. So that's the things that the surgeon is going to have to sort of balance out when they're deciding what to do. In a lot of cases, if the tear is big enough, they're just going to cut it out, smooth it down, and hope for the best. But anytime you start to change that articular surface of the joint, you're going to start to have some problems down the road and some arthritic changes as you get older. Okay, so joint contusions. Blows to the muscles crossing the knee joint. Usually present with knee sprains, severe severe pain, loss of movement, and signs of acute inflammation, swelling, and discoloration also there. Management depends on the location. You want to apply compression and cold until resolution has occurred. Recommend inactivity for the first 24 hours. If swelling occurs, continue cold application for 72 hours. If the swelling and pain are intense, refer them to a physician. And once the acute stage has ended and the swelling is diminished, cold application with active range of motion could be conducted, and then allow them to return to normal activity with protective padding when pain has subsided. So in these cases, we're kind of looking at these as, maybe we're thinking it's possibly something more significant, but we're really not seeing that locking with the meniscus. We're not seeing instability with the ligament injury. We're just kind of watching them and treating the symptoms and then slowly returning them back. Knee plica. So this is a pretty interesting injury. So plica is folds of synovial membrane. A lot of times there's a medial patellar plica. It's more thick, non-yielding fibrotic tissue, which can cause a number of symptoms. So basically it's tissue that never resolved when you were being formed in your mom's belly. It doesn't go away, and it becomes an issue. It gets irritated. So you may or may not have a history of a knee injury. Painful feeling that the knee is locking or when sitting for a long period, and the pain with ascending and descending stairs when squatting. So a lot of times these don't start to really hurt until you do something to sort of aggravate them. You want to do rest, anti-inflammatories, and local heat. If the condition reoccurs, it could cause chondromalacia of the femoral condyle, which is kind of a wearing down of it, or the patella. And the plica may require surgical excision. Bursitis. So I think we've talked about bursitis before. We talked about retrocalcaneal bursitis. So a bursa sac of fluid usually sits between a muscle or a tendon and a bone. So you have several bursa in your knee. You have the prepatella, the prepatellar bursa, which is kind of on top of the patella, the infrapatellar bursa, which is below it, and the suprapatellar bursa, which is above it. So you can have an acute bursitis where you get hit on the knee and you get the swelling, a chronic which comes over time, or it can be recurrent where it comes and goes. The prepatellar bursa becomes inflamed from continued kneeling a lot of times. The deep infrapatellar bursa may become irritated with overuse of the patella tendon because it's below the patella. A prepatellar bursitis results in localized swelling above the knee that is similar to a balloon, so it looks really, really enlarged. Swelling across the joints, of redness, increased temperature. An inflamed bursa may be very painful and disabling, and swelling in the back of the knee may be indicative of a Baker's cyst. A lot of times with meniscal tears, you'll get a cyst that forms in the back of the knee. You can also get them with bursitis. Care of these usually follows a pattern of eliminating the cause, prescribing rest, and reducing inflammation. Elastic compression wraps and anti-inflammatory meds. You may also need to aspirate the knee and take the fluid off the knee and do a cortisone injection. Okay, loose bodies in the knees. Sometimes you just get fragments of bone and cartilage that break off and will sit in the knee. It could be because of repeated trauma. It could be these bony fragments. It could be part of your meniscus. It could be some synovial tissue or a piece of a torn cruciate ligament. But they get stuck in the knee and may get lodged in the joint space and cause locking, pain and instability. It's not surgically, if it's not removed, it could cause further damage. So a lot of times you need to go in and scoop these pieces out. Iliotibial band friction syndrome. Lots of words there. So your iliotibial band is a structure that kind of originates up off of your hip as the tensor fasciolata muscle, which if we get to the hip we'll talk about, but then kind of comes down across the side of the leg and forms the IT band. You've heard it. I'm sure you've heard IT band before. So you can get what's called a friction syndrome. Okay. caused by malalignment or asymmetries in the foot or the leg with repeated flexion and extension. Okay, because as that band comes down across the joint, it does get exposed to the lateral aspect of the tibia and the femur and the fibula, and it can cause a friction on that muscle and on that tendon, and cause irritation of it. The way we're going to take care of it is stretching it, correction of what's going on. Maybe there's something going on in your lower body to correct. We need to correct it. We need to use ice ice after activity, to perform some sort of a warm-up with with heat, or stretching or biking. Avoid activities that aggravate it. Administer anti-inflammatories, and also may want to do some friction massage over the area to break up the inflammation. Fracture of your patella. The cause of it could be a direct trauma where you get hit on the patella, or it gets pulled. Indirect trauma is where it gets pulled. Direct trauma where it gets hit directly, or it's usually a forcible contraction, a fall, jumping, or running. You're going to have a lot of hemorrhage in the area. Indirect fractures may cause tearing of the joint capsule, separation of bone fragments, or tearing of the quadriceps tendon. Direct fractures involve little bone separation. Obviously, you're going to see these on an X-ray. Ice followed by an elastic bandage wrap and splinting. Refer them to a physician, and there may be a period of 2 to 3 months of immobilization. Dislocation or subluxation of the patella. Sublux means it goes out and comes back in. Dislocation means it goes out and stays out. Usually caused by a deceleration simultaneously with a cutting, so valgus force at the knee. So a lot of times you may see these valgus forces, and you're kind of trying to differentiate: did they do something to their MCL, or do we have a patellar injury? Very common in females to have this happen because they have a lot of patellofemoral problems anyways. Signs of the injury: complete loss of knee function along with pain and swelling. A first-time dislocation should always be suspected of being associated with a fracture. Immobilize the knee, refer to a physician. Following reduction, you can be immobilized up to 4 weeks on crutches. All the muscles should be strengthened around the knee, hip, and thigh. And after immobilization, neoprene sleeves, a horseshoe to help stabilize that patella. You should not really try to relocate these, although it may be relatively easy. If you just straighten out the knee, it usually will pop back in. Chondromalacia, we talked about this a little earlier, I mentioned it. But basically, we have a softening or deterioration of the undersurface of the patella, usually related to bony alignments, quadricep weakness, or wider pelvises in females. You're going to have pain while walking, running, and descending stairs, and squatting. There's going to be a recurrent swelling, sensation in the knee and a weird sensation in the knee during flexion extension. You want to avoid the irritating activities. Do pain-free isometrics. Wear a neoprene sleeve, and eventually you may need surgery. Okay, patellar tendonitis, usually caused by jumping, kicking, or running repetitively, which places tremendous stress and strain on the patella and quadricep tendon. Sudden and repetitive extension may begin an inflammatory process that leads to tendon degeneration. Signs of injury are pain and tenderness generally around the bottom of the patella, and the posterior aspect that worsens when engaging in jumping and running activities. There's several approaches, but rest is usually the very most important thing. Use of ice. You can do friction massage and anti-inflammatories. Brace, some kind of strap on that area may be used. You can use what's called a Cho-Patch strap, or even some kind of a neoprene sleeve with a hole cut out of it to put some pressure there, but that pressure helps to alleviate the pain, kind of redirects the pull of the muscle. Osgood-Schlatter disease, common to rapidly growing immature adolescent athletes. repeated pulling of the tendon. So this will occur down at the tibial tuberosity. So that's where that patella tendon attaches. And so maybe if you're growing too quickly, it's pulling and the tendon and can't keep up with it, and so you get that pulling of the tendon. You have a formation of a bony callus. Remember I've said before, bone's reaction to injury or to trauma is to make more bones. You end up with this lump there. Larsen-Johansson's is a similar condition, but it involves the inferior pole of the patella. So now we're talking about at the patella, not at the tibial tuberosity. Let's take a look at that in another picture. So we're going to get Osgood-Schlatter disease down here. Larsen-Johansson's is going to be up here. So you get this bone and this bone are growing and it's pulling everything, and then you get that bony formation here or here. Usually resolves as they get older. Signs of the condition: repeated irritation, which causes swelling, hemorrhage, and degeneration at the tibia tuberosity. Severe pain with kneeling, jumping, and running. Point tenderness over the anterior tibial tuberosity. These are pretty easy to figure out because you have usually someone with a lot larger tibial tuberosity there and a pain there. Stressful activities are decreased for approximately 6 months to a year. Severe cases may require padding. Ice is usually applied, and isometric strengthening of the quads and hamstring muscles is performed. Okay, so that's it for us for the knee.